Samad, thank you for joining at a very short notice. We're just waiting for Dr. Jula, who is the presenter, to log in.
Hello.
Hello.
Yeah, I can't hear anything. Have we started or not yet?
No, not started yet. We're just waiting for the presenter.
Okay.
Okay.
Is he coming from far?
No, he's here, but he's having connection problems. So we'll just hopefully he will be able to sort it out.
Okay, can you please keep us updated? Tell us who is the presenter and
Yes,
from
yes.
where?
Yes,
Huh?
we'll do that. Yeah. Presenter is Dr. Jula. He's our registrar in pediatric surgery. And chief guest or Dr. Jula, he's registrar in pediatric surgery in East London in South Africa.
Mm.
And invited guest is Professor Sheikh, who is the president of the College of Pediatric Surgeons of South Africa.
Okay.
Okay. Where do you work? Where are you from?
Yeah, I'm Dr. Safwat Andraus from Nairobi. Yeah.
Okay. Okay. No, welcome. Welcome. Let's just hope that Dr. Jula can sort out the connection issue. I will keep.
It was also written in the meeting that Dr. John Lazarus is also would be around.
So, Dr. John Lazarus or Professor John Lazarus was the initial invited guest, but he informed me just an hour ago that he is unable to join. So at the last minute, I have requested Professor Samad Sheikh, who also has significant experience in bladder exstrophy, to join us as invited guest.
Okay.
Okay. So let's just wait for a little longer. I'll just find out from the presenter.
No problem. Thank you.
Yes, how far are you, Zadile? Are you connecting? Okay, no problem. Yeah, okay, no problem. Connect and you can actually load your presentation straight away. Thanks. Okay. So Andile, you can load your presentation. You can start sharing the screen straight away.
All right.
And just give a very brief introduction and then you can start.
Okay. All right.
Okay, you can go into the presentation mode so long. Okay, just hold on 1 second. Okay, good afternoon, everyone. We are sorry for the delay. Dr. Jula just had some connection problems. So today, Dr. Jula, he is our registrar in pediatric surgery in East London, is going to give a brief talk about bladder exstrophy and Epispadius. Due to time shortage, we have not included cloacal exstrophy in today's talk. And Professor John Lazarus from University of Cape Town was going to be the invited guest, but at the last minute he had some work emergency, so unfortunately he cannot join. And I'm very glad and thankful that Professor Samad Sheikh, who is the president of College of Pediatric Surgeons and a senior pediatric surgeon in Durban, agreed at the last minute to join our meeting. Professor Sheikh is joining, but he's also busy in the NICU. So he will comment when he gets time. So without losing much time, I just ask Dr. Jula to start his presentation. Okay, Zwandile, you can go.
All right. Thank you, Prof. And apologies for the delay. I just had some connection issues. So as Prof has mentioned, we're gonna speak about bladder exstrophy and Epispadius today. So with just a brief introduction, the Epispadius Estrophy and Epispadius complex, it's a wide spectrum of disease, of malformation that actually varies from Epispadius, which is mild, into the worst malformation of cloacal exstrophy. The prevalence of these malformations as grouped is 1:10 live birth. But with the classical bladder exstrophy, it's a lot more rare, and it's 1 in 30,000. And with the cloacal exstrophy, it's even more rare, when it's 1 in every 200,000 live birth. And it seems to be affecting more male than females. So just to touch on embryology. So just after the developmental stage of just after the 3 weeks, where you have your urogenital sinus forming and the cloacal membrane there in front, and between week 4 and week 6 of gestation, you get the formation of urorectal septum, which eventually goes and fuses with the cloacal membrane anteriorly. And that divides the rectum from the urogenital, from the primitive urogenital sinus. Yes. So there are a couple of hypotheses on what happened on the development of these exstrophies and cloaca. So one of the hypotheses is that there's a premature rupture of the cloacal membrane, which then results in the structures being exposed to the external environment. And depending on when this happened during the embryological development, you either get just Epispadius or Epispadius with a bladder exstrophy or the cloaca. So if this insult happens between the 4th and the 6th week, before the urogenital sinus fuses with the cloacal membrane, then you will end up with cloacal exstrophy. But if this insult happens after the urorectal septum have fused with the cloacal membrane, then you end up with a milder cases of either bladder exstrophy or just the Epispadius. The other hypothesis of this development that is mentioned is actually the mechanical obstruction of the mesodermal cells to migrate anteriorly to where they will become anterior abdominal muscles and all the subcutaneous tissue. And the last one is the disruptive in cellular function, which just results then in just abnormal sporadic development. But in most cases, most authors have described that it's actually the combination of all these hypotheses that actually gives us this, this malformation. Okay, yeah. So as we've mentioned that you get Epispadius, which is just the urethra is partially or completely an open plate on a dorsal surface of the phallus. So it can extend towards the end of the penis. It can be just a segment of the penis. And then your classical bladder exstrophy is when your bladder is exposed on your anterior abdominal wall. You have your posterior wall of the mucosa everted outwardly, giving you this reddish appearance, and it also comes with a certain level of hyperspadias as well. And then you get your cloacal exstrophies, which are more complex, which can include omphalocele, the exstrophies, and imperforated anus, as well as spinal defects. This is just a schematic representation of what you would see if you're looking at the baby that has just been born with bladder exstrophy. If you look at number 1, you have our low set umbilical cord. And number 2 is show you the surface of the bladder that's bulging in, and you can see the ureteric orifices at number 4. And number 3, you have your paraestrophy tissue. Also, the verumen internum is shown there, and actually these kids, they are born with normally working ejaculating duct, which actually comes out around that area of the verum. As you can see, they've got a flat glans and a short phallus as well. So this is what it look like when you're looking at the baby. You have the umbilical cord on top, and then this red bulge, which is an everted bladder with a splayed penis that you can see a urethral plate on top. And as you can see, the prepuce is lying on the ventral surface. So these kids also, they can have inguinal hernias, undescended testes, but their upper urinary tract is usually normal. Also, they are prone to vesiculoureteric refluxes by the way that their ureters enter the bladder more on the lateral aspect. Okay, so this is just showing a schematic representation of what a normal penis would look like, and what on the left, that is your Epispadius penis, what it would look like. So the main difference is the size. It is noted that the baby is born with with exstrophies, they have almost less than 50% the size of the normal phallus or of the baby that doesn't have any exstrophy. And with the widened symphysis pubis, it also pulls on the corporal as well, on the corporal tissue. So you have this shortening and of the phallic tissue and this flat glans as well, with an anteriorly placed anus. So in females, it will present about the same. You will still get your pink bladder protruding on your lower abdominal space. And on this case, you can see the bifid clitoris, and they usually have a shortened urethra, which is also placed anteriorly, as well as the vaginal opening that is stenotic. Usually the uterus and the adnexal organs, they are normal. So with the diagnosis of this condition, the condition can easily be diagnosed with a prenatal ultrasound. The classic sign is the absent bladder, which is about 71% of the patients have that. But you can also see anteriorly displaced scrotum with a small phallus in the male, as well as the obvious bulge on the lower abdomen. As we mentioned as well, the umbilical cord tend to hang lower than normal. And with the scale sonography, they can actually be able to see also the widening of the pelvis, because in exstrophy, the actual pelvis, it's like an open book pelvic. So looking at principles of management. So initially, you need to have surgical reconstruction. So the main important part is the closure of the native bladder as soon as possible. And so this is done preferably within the first 24 hours. But if there aren't skills in that center, the patient can still be sent to the center where there are adequate skills, because that's what these patients actually are gonna need, the specialized care. So, but if your main objective, you want to create a functional urinary storage, you want to close the Epispadius and try to create as normal as possible genitalia. And as they grow, you want to achieve continence and preserve sexual function as well. And this is determined by the success of the initial operation. The very important part is to get that initial operation done correctly and successfully. So the initial management of the patient, you try and remove the plastic clamp if the baby has already have an umbilical plastic clamp, because it irritates the bladder. So you can use a silk suture, and you have to keep the defect moist. You can cover it with something that will retain moisture, like plastic or cling wrap. And then you also have to look for other anomalies. You can do a renal ultrasound and with your rest of your general examination. And these babies need to be started on IV antibiotics because of the exposure of the bladder. Okay, so the closure of the bladder can be done in in two ways. It can be done as a modern stage reconstruction of exstrophy, or it can be done as a single stage. But the most widely used is the staged approach, which initially you prioritize closure of the bladder with or without osteotomies. So if the aim to do this early disclosure early is that within the first few days of birth, actually the other authors, they say that you can still try to do the closure of the bone without osteotomies up to 72 hours. But after that, you're gonna have to do osteotomies because then the bones get stiffer and you really can't be able to bridge the gap between the pubic symphysis. So the idea is you have to close the bladder and return it into the pelvis and have an adequate closure of the bony pubic symphysis with or without osteotomies. If you can't manage without osteotomies, then you're gonna need orthopedic support to help you with osteotomies. And once that is done, you also on this operation, also what you do, also fix the posterior urethra. And even with that, it does help with some form of some resistance to have some capacity of the bladder. Some authors have mentioned that at this stage, you can defer the procedure if the baby is born with a very small fibrotic bladder, that you think that you can give some time and let it grow before you do the primary closure of the bladder. And there are cases like that that have been reported with a delayed closure. On the second stage, which is the one that is done in late infancy. So the most important part here is to repair the Epispadius. And during this time, because of the small size of the phallus, some of the patients, they might have received some testosterone injection as well. But the goal here also is to repair the Epispadius. There are a couple of ways that you can do that, but also it is described that if you can't get the urethra all the way to the tip, you can actually convert the Hypospadius into, the Epispadius into Hypospadius to repair the Hypospadius at the later stage. So you pull down your urethral meatus on the ventral surface of the phallus. And then the last stage is undertaken just before the school age. And this is bladder neck repair with reimplantation of ureters to prevent a vesico-urethric reflux. Some authors have observed that after they have done Episparius repair successfully, the patient some patient can have some form of continence, and they do not need further bladder neck reconstruction. But with the bladder neck reconstruction comes in a reimplantation of the vesico-urethric of the ureters to prevent the refluxes. So this is just a schematic representation of the process of the initial procedure. You basically have to dissect out the bladder from the skin and from the anterior abdominal wall muscles. And in doing so, you have to also pay very good attention that you don't, with your dissection and your suturing, that you don't injure your ureteric opening. You can put in feeding tube or stents to make sure that you don't injure them during this operation. But also during this part, you also put in a suprapubic catheter that's going to be the drainage point for your urine. Once the bladder is closed in 2 layers and pushed back to the pelvis as possible, and then the attempt is made to close the pubic symphysis. So that is done with or without osteotomies, depending on when it's done. The patient can then be put on either external fixation, or you can have some form of immobilization, like the mermaid wrap that they do, and then you hang the baby up on the bed to stabilize the pubic symphysis anastomosis. So this is schematic representation of the osteotomies, and the arrows actually shows what you're trying to achieve, that you're trying to close that anterior gap, and it can be closed with a strong non-absorbable sutures like at the bone. We've been able to do it with those sutures. And then the second stage also involved the Episparius repair, which mainly what you want to achieve with the epispadial repair is you want to correct the dorsal chordae, you want to reconstruct the urethra, you want to reconstruct the glands, and also get adequate skin to cover the penis. And with all of these things will help you achieve the closest to normality that you can get. And then only after, then if you've had a successful closure, then you go in and do at the later stage, the stage 3, where you do your bladder neck and reconstruction and reimplantation of the ureters. So also here, the main aim is to also create some form of pressure at the bladder neck that is going to, one, motivate the growth of the bladder with cycling with the bladder filling, and as well you want some form of continence, some form of control without refluxes to the upper urinary tract, which is why you also need to do reimplantation of the ureters. So the primary closure procedure. So this is where basically the closure of the bladder, the pubic symphysis, and the repair of the Epispadius is done in a single operation. And also in this case, if the urethral length isn't enough, you can form a hypospadic meatus for a reconstruction later. With this operation, they don't do bladder neck reconstruction on the same operation. It's just the repair of the bladder and the closure of the pubic symphysis, as well as the Epispadius repair. So complications that we face with this procedure, the main one is wound dehiscences. So this can happen if it's under tension, if there is an infection, you get wound infection, And this can actually cause a failure of your anastomosis and the breakdown of the wound. And which is basically, it's advised that you treat the sepsis, you treat the cause, you give the bladder time to heal. You don't rush to go back and redo the procedure. And you plan to redo the procedure as a failed or salvage form of procedure at a later stage, where you also feel that you have enough and healthy bladder tissue, or if you have chosen then that you're going to abandon the bladder, then you can do other procedures, or if the bladder needs augmentation as well, and then we'll just discuss that at the later stage as well. Other complications include urinary incontinence. You also get urethrocutaneous fistulas. Cancer is also reported by the time these children are adults. And there's a lot of issues around fertility and psychosocial issues with sexuality and sexual identity as well. So I'm going to touch on quickly on urinary diversion, which forms part of the management of these conditions. So you can either have your incontinent or your continent urinary diversion. Where you're incontinent, you'll have any form of a urostomy that is draining either into a nappy or into a urostomy bag. Whereas in a continent diversion, you need a reservoir inside the body and a conduit where that controls basically like clean intermittent catheterization, so that they will have some dryness during the day. Some indications are also for bladder exstrophy, complex cloaca, or salvage procedures. So your incontinent urinary diversion include your cutaneous vesicostomies, where it's just a bladder that's connected into the skin, or you can have your cutaneous urostomies, which can be fashioned in different ways. It can be a loop, it can be an end urostomy, and there's also a Sobati urostomies. Also, bowel, ileum, and colon have been used as conduit before. So this is an ileal conduit where you have both ureters draining into the ileum, and you have an ileourostomy. Continent urinary diversion also is the same indication. And in this case, you need to have a reservoir, a conduit, and a control system. So what you can use as a reservoir, you can use a stomach, you can use ileum, you can use cecum, and the colon as well. Your conduit could be the appendix, as in Mitrofanov, or ileum with a cork valve, and ureters as well, and fallopian tubes have been described before. So your control system, there's Mitrofanov, which uses an appendix, which is dissected with its blood supply, and the widely open part that is attached to the cecum is the one that is connected into the skin that form a cutaneous fistula, and the small part is the one that forms a valve and is connected to a reservoir. And then you also have a cork valve, which basically uses a segment of bowel and intercept it to each other, causing some form of a valve. And there's Indiana valves, which use the natural ileocecal valve and the cecum. And there's also an anal sphincter, where you have diverted the urine into either a sigmoid or down into the rectum, and the anal sphincter just act as a control mechanism. So with most of these, you're going to need bladder augmentation, and with that you use your gastrointestinal tissue. So mostly you can use your ileum, sigmoid, also your ileocecal, taking both the ileum and the cecum. And also you can use the stomach as a reservoir as well to augment the size of the bladder. So there's Mitrofanov, as I was describing, that you mobilize the appendix with its blood supply and turn it around so that the biggest part, the one that's attached to the cecum, is the one that's forming a fistula. And this can be drained with your clean intermittent catheterization. This is the representation of Indiana pouch, which took part of the cecum and the ileum, and using the ileocecal valve as a valve. So there are multiple complications with these procedures as well. As you can imagine, you also taking from other organs, so there will be structural defects from the stomach, from the intestine, wherever you've taken your tissue from, and you lose some intestinal segments. But the other issues include secretion into the bladder, which is not common, that can cause actually bladder stone. And there is also reabsorption of the waste matter from the urine, the ammonia, that will also give you electrolyte imbalances. And the risk for malignancy is also very high. So in summary, I would say it is the initial success closure of the bladder that will determine if the patient is going to have adequate continence and function of their genitalia. It is a wide spectrum of malformation, and it's a complex to manage. It needs a multidisciplinary team, preferably a specialized center with adequate counseling as well to the parents, and also a continuous conversation with the parents, so that also you discuss realistic outcome as well, because these diseases can vary from very mild form to a very severe form. And there's also a lot of psychosocial implications that we just need to be aware of, even with these kids going up to adulthood, as matters of sexuality and fertility also, it does remain affected. That's all. Thank you.
Thank you, Zandile. That was a very nice presentation, and you seem to have a good understanding of, as you said, it's a very complex problem. It's not a common problem we deal with, and there are multiple things to consider about repair and its implications. So well presented, nice diagrams, and good understanding. And I don't understand myself when you say that if you can't repair the Epispadias completely, you may convert it into a Hypospadias. That's the only concept which I don't understand. So do you know what exactly you're talking about? Because if you can't repair it completely, then you just do whatever you can. So what do you mean by converting it to Hypospadias?
Okay, Prof, what I found from some of the others here is that, so instead of on the initial phase of repairing the Epispadias, and if you're not getting adequate tissue to create your urethral plate,
yes,
you can sort of invaginate that urethral plate that you have, the short one, but push it between the corporal tissue, so that it comes out. It comes out as a hypospadias.
I see, on the ventral side.
On the ventral side.
I see. Okay. No, that's perfect. I hadn't come across it, but what you have explained to me correctly. And no, glad you included urinary diversions, because I was surprised to read that urinary diversion is advocated at many centers for this procedure, for this complex problem. So let's just get our guests to comment. I wonder if Professor Sheikh is available to comment. Samad, are you able to comment?
Hi, Milind. Yeah, I can. Sorry, as Milind explained earlier on, it was a last-minute call, and I'm still at work. So I just have a few practical comments to make. I must say this was an exceptional talk. The registrar covered everything that needs to be covered. Most importantly, like Prof. Chitnis mentioned, I think the registrar has a good understanding of the concepts of what he was talking about. And for a difficult subject like this, that's something that's applaudable. So for the registrars who are listening in, this is a very good talk to have an understanding of a problem and an abnormality that we see rather infrequently. So I can only add a few sort of practical comments that from my own experience. Until about 7 years ago, we were still seeing a fair number of these patients, about 3 to 5 a year. And then about 7 years ago, when we started having a fetal service, which was really sort of going very well, almost all of the parents who have had this diagnosis made, and there is certainly a fair hidden sort of mortality from this condition, almost all of those parents have opted for a termination of pregnancy. So over the past couple of years, I've seen probably 1 a year, and these have been patients who have been missed, where the diagnosis has been missed. So it's very infrequent. So from the point of view of the antenatal diagnosis, the termination of pregnancy is still the preferred option of many parents. And this is what our fetal specialists tend to push because of the complexity of the abnormality and the problems related to the long-term outcome. And we have to be cognizant of the fact that this influences sexuality and normal social functioning significantly. Postnatally, I still, because I was trained in the complete repair, we still always try and do the complete repair at the initial stage. I usually try to approximate the pubis symphysis without any osteotomies, but if we need to do an osteotomy, we try for an posterior osteotomy as our primary mobilization, and if not, we do sometimes do an anterior osteotomy. In relation to the osteotomies and mobilization of the pelvis and approximation of the pelvic bones, what we have realized as these patients have grown older, that radiological approximation is not as important as having a child who can walk properly and not have a problem in terms of their gait. So you may not have to get the pubis symphysis in close approximation with each other from a mobility point of view. Some people do think that it may play a role in terms of continence, but certainly from a mobility point of view, we have found that children who still have a slightly open pelvis are able to mobilize very well in their later years. From the repair side, they always require long-term care, whether we do the staged or the complete repair, they always require long-term care. Most of this is related to try and improve the bladder, and in males to try and improve the cosmetic appearance of the genitalia. Like I said, we have very few over the recent past. So for those patients, we are still in the process of allowing them to grow, their bladders to grow. But I've inherited a fair number of patients from Prof. Hadley and Mr. Viersma who are now in their late teens or early adulthood. And the one thing I have found in about 3 of these patients is that they have all elected to have a permanent diversionary procedure performed. And by the time they reach high school, early university years, a diversionary procedure as their final procedure is often preferred to the incontinence and the other related problems that they may have with their bladder related issues. The one advantage that we have had in 2 of these patients, which were male, was that with the diversionary procedure, we've been able to pay more attention to the cosmesis of the genitalia, and both have had a successful reconstruction of genitalia, which look and function acceptably. So I think that's an important aspect to remember. I think the rest of the theory has been well covered. Not sure what other sort of practical points I can share, except the ones that I've mentioned already. Any specific questions, Melinda? I think I'd rather answer that because I was caught a little bit off guard rather than trying to give a more structured answer to what I had explained.
No problem at all. I mean, we really appreciate you making a plan at the really last minute, but thank you. I was interested and intrigued by your comment that many parents are now opting for medical termination of pregnancy, but that's interesting. And I'm glad that you have also mentioned Prof. Hadley and Mr. Wiersma's experience that patients choosing a diversion for urinary drainage, and then the genitalia basically are reconstructed for cosmesis, and then they may be useful for a sexual function in addition to a proper genital identity. So thank you for those comments. Dr. Safawat has a question or a comment. Dr. Safawat, please go ahead.
Yes, thank you very much. We have this experience in Nairobi for the last almost 30 years. In Kenya, we have been dealing with these cases, and it is agreeing with you, it is one of the very challenging conditions with a lot of complication, and we needed really to have somebody who have special interest in doing them. And we have done all this staged repair and modified, complete repair. And the biggest challenge was the continence.
Yes.
Even with all the staged repaired, it is really the continence, they are incontinent. And it is really make people very unhappy, and they can't go to school and they live miserable life. And what we have opted for in the last 20 years or so, or 18, 15 years, we have to do diversion. And what we are doing the standard Mainz pouch, which is modified urethral sigmoidostomy. So we make a pouch out of the colon, sigmoid colon, and then we really implant the ureter there. We have 30 cases, 30, who have done this, and some of them now are 18 years, lived with it for 18 years, from 2002, very happy, went to college, and even finished, and they are working. And as the chairman said, that when we really divert the urine to the colon, number one, really here in Kenya and in many places, people don't want to do intermittent castration. They have no even water at times. They have no clean running water. They have no enough money for supplies for catheters. And with a lot of infection and complication is not practical. The one for Mainz pouch, the urethral sigmoidostomy modified, they have very low maintenance. They don't need, and we don't have any complication with electrolyte or bicarbonate supplement or anything. And the other thing is that this allows us to do freely repair the Epispadius and also repair the, the size of the penis. That really makes a lot of difference. And I really recommend it as a primary type of approach. We still get children up to now, 15 years, 18 years, who have never been attended, and they are hiding in the rural areas, not able to go to school, miserable life. And this is what we do. And we also, anyone who have any failed exstrophy repair, we now advise them at the school age, 6, 7, 5, 6 years, to do diversion, and they are very happy from it.
Thank you very much, Dr. Safawat. That is a commendable, huge amount of experience, and thank you for sharing your views. And I think the juniors need to hear that diversion has a significant role in the management of exstrophy. Professor Sheikh wants to make a comment. Samad, please go ahead.
Thanks, Milind.
Yes.
I think those are very valuable comments from Dr. Safawat. I think they're very sensible. They are really good comments, and I'm really glad that he has such a long experience. I mean, 18 years is exceptional for those kiddies. And it's certainly the mains 2 pouch, the modified mains pouch is my preferred approach as well now. And a couple of years ago, when they had a colorectal workshop at Red Cross, our visitors from the United States have also said that they are trying to move on to performing those for the cloacal exstrophies as their preferred approach. And I think one of them said that they have a patient who's about 22 years old with no malignant change, no electrolyte abnormalities, and no real issues. So given the group of patients that we get, which are probably very similar to what they see in Nairobi, I think the advice that Dr. Safawat has given is exceptional, especially for the registrars and for all of us who do see these patients, to realize that surgical technique.
Sorry, Samad, we have lost you now. Samad? I think there's some problem with Professor Sheikh's connection. So I will invite Dr. Majula, our consultant pediatric surgeon, who deals with urology and with special interest in urology, to make any comments. Dr. Majula?
Hi, Prof. Thanks for the opportunity. Well done to Mzwa for the good presentation and just a well-covered topic. And as mentioned by all the other commenters, that it's a very rare entity, and also trying to deal with it is very complex. And you try by all means to do what you can with the little that is provided by you by embryology development. When I was with Prof. John at Red Cross, because we saw quite a few of these patients. So what he had mentioned was your sort of best opportunity to try and make a sort of near normal anatomy per se, or to fix what the problem is your first operation.
Yeah.
So whichever you choose, in either you want to make it into a staged or you want to try the modified complete repair. But your first operation will sort of realign as to what you can do next. And then also with as the others have mentioned, incontinence is also the major problem. So he has also chosen to actually close the bladder neck and just do a diverting continent stoma for these kids. With some of them, he has that when I was there, with bladder augmentation at the same time. But with those, the ones that we've augmented, he was still using small bowel for the augmentation. So you're using ileum. But yeah, that was the main thing. It's just that these kids have incontinence and they can't deal with it. And as mentioned, from an anatomy point of view and just from a practical point of view, some of them don't like CICs, especially in the genital region. So that's why it does diverting. It diverts the urine for them. But yeah, thank you.
Thank you, Kulileko. And yeah, I think it's also very important what you mentioned is that the first operation is the best chance for the patient. So it's almost like posterior sagittal anorectoplasty for anorectal malformation. So the first operation should preferably done by a surgeon who knows what operation to do, who is conversant with it. And the books advise that if for that reason, if the first operation needs to be postponed for some time, maybe few days, even maybe few months, then it's not such a bad thing. So that an experienced surgeon with competence does the first operation rather than somebody trying to do something without knowing exactly what to do. Thank you, Kulileko. I'll just invite Dr. Manik Chand, our consultant pediatric surgeon, who is trained in Durban, if she remembers anything different done by Mr. Viesma or anything else she would like to comment, Dr. Manik Chand.
Hi, Prof. Thank you. Yeah, I would agree with everything that's been said by our commenters so far, and well done to Zandile for the talk, for including the bladder augmentation and the continent procedure or the urinary diversion procedures, because invariably these children have very small bladders. So, and I know, you know, we teach that we close the bladder neck, or we try to tighten it and try to create, you know, a mechanism for stretching that bladder over time. But from my limited experience of training under Mr. Wiersma, it seemed like most of them needed augmentation. And like Prof. Sheikh is saying, at some point, they opt for diversion anyway. So I think maybe we should be thinking about this early on and doing early diversions like our colleague in Kenya has been suggesting. I think that would really improve our patients' morbidity and complications and just quality of life, even when they are young. So I think we should really consider that. I know that we did do, I know Mr. Wiersma's preferred diversion procedure was the Mitrofanoff continent procedure. But we did do some urethral sigmoidostomies, but it was preferred not to because of the risk of adenocarcinoma. So it's good to hear that from other experiences that wasn't always a problem. So it might be a better option because of, you know, it's technically easier. And also it doesn't require CICs. So some patients might, like Dr. Sarvat from Kenya was saying, they might opt not to even have a continent stoma because that would require them catheterizing themselves. So yeah, I think the topic was covered really well. And those are my comments. And I think, yeah, we need to be very mindful of the fact that they will end up needing a continent procedure. So the earlier, the better.
Thank you, Yashoda. I think if my understanding is correct, the mains procedure with urethral sigmoidostomy has much less, almost negligible rate of complications, including very little incidence of adenocarcinoma as compared to a standard urethral sigmoidostomy. But I think you have also suggested it very correctly. Our other consultant, Dr. Machaya, I think is also here. So Selo, any comments?
No comments, Prof. I think I'll just be repeating what every comment has been saying.
Yes.
And good presentation, Zandile. Thanks.
Yes, Selo, thank you very much. Thank you. I think I'll just ask Professor Sheikh if he's still around to make final remarks before we close down the meeting. Samad, any final comments, final remarks?
Thanks, Milind. I think my final comment will probably relate to us realizing, especially since you have a much younger audience there, but we must realize that whatever we do early on in the neonatal period or in the first 2-3 years of life are going to have long-term consequences. And much, much later on, maybe even after you've retired, is when these children are going to need to be able to blend into society and function adequately. And I think that, for me, has been the biggest eye-opener, as I've inherited these children from at an older age, 18, 19, 20. And that's the age that they will require a balance or a decision that we need to make between getting a bladder that looks good, a bladder neck that we think we've constructed properly, penis or genitalia that may or may not be acceptable, as compared to getting a properly functioning penis, which will suit the child, suits the adult, and at the same time having a child who can engage in social activities in a continent fashion. And I think that probably, for me, is an important aspect for us to realize that even though we may have changed our techniques of bladder reconstruction in the neonatal period, we have to remember that these children are going to become 17, 18, 19, and 25. And during that time, we have to make sure that we have something in place. And I've become a big fan of a continent urinary diversion like the mains type 2 procedure for these children. I think that should summarize what I have to say, Mohan.
Yes, no, thank you very much, Samad. I think it was really wonderful to have you to be present with us, and we really appreciate you helping us at the shortest possible notice. And thank you again. Thank you for Dr. Safawat. We would appreciate his presence in the future meetings and his contributions. So well done, Zwandile. Next week, there will be a presentation on inflammatory bowel disease by Dr. Pedersen, our medical officer, and Professor Robin Brown, who is a senior pediatric surgeon from Cape Town, will be our invited guest. So thank you, everybody. Have a good evening. And thanks once again to Professor Sheikh.
Thank you.
Thank you. Bye-bye.
Thank you.